Okay, let's go ahead and get started. Thank you all for being here. Welcome to the June 2020 Whatcom County Coalition to End Homelessness meeting. Can you guys hear me? Yeah? Great. I'd like to begin by acknowledging that we gather on the ancestral homelands of the Coast Salish peoples who've lived in the Salish Sea Basin throughout the San Juan Islands and the North Cascades watershed from time immemorial. Please join me in expressing our deepest respect and gratitude for Indigenous neighbors, the Lummi Nation and the Nooksack tribe for their enduring care and protection of our shared lands and waterways. My name's Terry Bryant. I'm the director of the Whatcom Homeless Service Centered Opportunity Council. I'm excited to be the new chair of this group. For folks who may not know me, I worked for Mike Parker in the Homeless Service Center for 4 years. Before that, I owned a small business downtown for 7 years, and I've got about 12 years experience in real estate lending and escrow. Before I introduce our speakers today, I'd like to do a little bit of Zoom housekeeping. Everyone is muted as you join, but if you'd like to speak, you're free to unmute yourself. If it's possible, I'd invite you to turn your cameras on. We are recording today's meeting, and in lieu of a sign-in sheet, I ask that you please introduce yourselves in the chat window and include any changes in your contact information that you'd like us to update or any announcements that you'd like to share with the group. Also, if you hover your cursor in the top right corner of your camera stream, you should see the mute or unmute option, and there's 3 dots. If you click on those 3 dots, you can change the way your name is displayed so we can connect your name to your face. So I know I'm Zoom 1 right now. I'll go ahead and change my name too. Okay. Today's meeting topic is supporting our strategic plan to end homelessness. The plan identifies that the highest self-reported needs at the point of intake are mental health and chronic health concerns, and it identifies disparities in homelessness for persons of color and LGBTQ populations. This topic is timely considering the current health crisis and the global outcry against racism and oppression. I want to express that we stand in solidarity with those struggling against racial injustice and oppression. And related to that, I wanted to share a quote by Brene Brown, and it is, "People are opting out of vital conversations about diversity and inclusivity because they fear looking wrong or being wrong. Choosing our own comfort over hard conversations is the epitome of privilege, and it corrodes trust and moves us away from meaningful and lasting change." To help facilitate some of these conversations, I've added a link to some resources in the chat window on coping with and addressing racial trauma and oppression. I hope you'll find that helpful as we do this work together. And I look forward to working with the coalition on these disparities going forward because Black Lives Matter. 2 pillars of the strategic plan that connect to today's presentations are cross-sector collaboration and the importance of high-quality case management. I'm really grateful to have these presenters speak to these pillars today. Also in the chat window, you'll find a link to our SurveyMonkey on future meeting content. Please feel free to complete that survey as you're able to, and if you haven't done so already. We've got several guests today. Mike Parker's here to talk about his new role at Opportunity Council. Paige from Queer Youth Project NWYS Youth Services is joining us to speak about the significance of Pride Month. And Geracie from PeaceHealth, Erin Smith from Lydia Place, and Jennifer Mune from Unity Care Northwest are here for a panel discussion on healthcare and homelessness. Mike, would you like to go ahead and start? Are you able to unmute yourselves? This is my second Zoom, so.
We're on mute.
Okay. Mike, are you with us?
I saw him earlier.
I see him in the participant window.
Yeah.
He said in chat that he's having a little trouble with audio.
Oh, okay. That's okay. Paige, are you okay if we skip ahead to you?
Yeah, I'm just fine with that. Shall I?
Yeah.
All right. So
Thank you.
I'm Paige, and I'm part of the team at the Queer Youth Project at NWYS Youth Services. I've been there about 4 years, and I've been working with and alongside the LGBTQ community for a little more than 15 years now. And I'm so grateful that I was invited today to share about the significance of Pride Month. And I don't think that this conversation could be any more timely than it is right now. Before we do that, I'd really like to tell you just a little bit about the Queer Youth Project so you're familiar with our programming. So our role is to build networks of supportive peers and adults around every LGBTQ young person in Whatcom and Skagit County. So, you know, not a lot of work. And we do that in two ways, primarily. The first is through supporting adults who are caring for LGBTQ youth. So that's training or consultations, answering questions, offering appropriate referrals for LGBTQ youth. The second way, and that could be pastors or parents, teachers, school administrators, social workers, nonprofit folks like yourselves. The second way is by creating supportive spaces for LGBTQ youth where they can connect with one another, with healthy queer and trans adults, build a sense of community and learn a lot about things like self-care, healthy relationships, and dealing with minority stress, etc. So those are the two primary ways that we go about this work. And we're part of NWYS Youth Services. And so our primary goal is to reduce homelessness for LGBTQ youth. So about 40% of youth experiencing homelessness at any given time are LGBTQ identified. And the number one driver for that is lack of parent or guardian acceptance. So it could be that a young person comes out and they're kicked out, or it could be that they come out and home becomes so toxic that sleeping outside feels safer. So that's a little bit of the background of what we do and the perspective that I'm speaking out of. I am going to ask you to participate in a little bit of a thought experiment with me right now. What I'd like for you to do is conjure up a memory of a time when you felt a real deep sense of belonging. Maybe that was to a group or to an individual person. Maybe it's a place where you feel a deep sense of belonging, or perhaps it's even an event that happened in your life that gave you that deep sense of belonging. And I'd like you to think about two things in particular. One of them is, what were the cues that you received that let you know that you belonged? And then the second question is, how did it feel? How did it feel to belong? So let's just sort of steep ourselves in that memory for about 30 seconds and think through those questions. What were the cues that told you you belonged? And what were the feelings that were associated with that? And then I'm going to ask you to come back and share in a way that's not very vulnerable. So no worries, don't worry about it. But just think about that for about 30 seconds. All right, those of you whose faces I can see, I could tell that you were deep in thought, sort of looking off into space, remembering this time. But I wonder if everybody would be willing to participate by sharing in the chat some of the ways that they realized that they belong. What were some of those cues that you were given that told you you belong here? So if you would just go ahead and chat a word or a brief phrase. Words of affirmation. People asking about you, interested in how you're doing, feeling valuable. Loving teasing. Okay, you felt supported. High fives. You had choice or agency. You had the keys to each other's apartments. That's wonderful. People being happy to see you. Being able to express yourself without any judgment. That's a big one. Non-judgmental. That keeps coming up. Smiling faces, hugs, trust, responsibility, people trusting you. So it seems like some similar experiences there. Thank you. Right now, would you share with me how that felt? Do you have a word or a brief phrase about how that experience of belonging felt? People say we missed you, right? Yeah, you were missed when you weren't there. Warm, peaceful, safe, validating, unself-conscious, so you could just be yourself. Yeah, accepted, happy, satisfying, comforting, affirming, easy, secure. So it sounds like there's a ton of overlap for folks in how this felt like a safe place where all of who they are was accepted, where people saw you and took you seriously and you were just okay. You know, we know that this experience of belonging and these to people, to having who you are reflected back to you in a positive way is actually an important protective factor. It doesn't just feel good, but it's actually an important way that we care for one another and we take care of ourselves. And that having those connections to healthy community and a positive view of ourself is really resilience building. And for me, that is one of the primary roles of Pride. It's a place to just be, a place to belong, a place to let down your guard, and a place to surround yourself with people who have had similar life experiences, a place you don't have to wonder if you're welcome, right? And the significance of having it recognized is powerful, because as a minority, you can feel like the rest of the world isn't listening. And so when the larger community steps up and says, we recognize Pride Month, when important politicians step up and recognize Pride Month, there's a validation, a sense of protection, a sense of being seen that comes both from within your circle and from without. And so that's one of the reasons why, to me, Pride Month is so important. You know, I want to make a couple comments about where we are in terms of queer and trans rights, or LGBTQ rights and justice. We've made a lot of progress as a community. We have marriage equality. Many states have anti-discrimination laws. Washington State even includes gender identity and expression in their anti-discrimination laws, which means that we also protect transgender and non-binary people, at least in theory. We protect them. There's that validation piece again, right? And we have a lot more visibility as a community, and even a lot more social acceptance. And still, the work of relieving suffering for LGBTQ folks and bringing more justice continues. I'm gonna take a risk and say that I think a lot of the gains that we've made for the LGBTQ community have been enjoyed most by those people who already benefited the most from society. So a lot of white people, a lot of middle-class people, a lot of cisgender people. I myself enjoy the benefits of this, having been married for 4 of the 5 years that marriage equality has been the law of the land. Transgender people in particular, especially Black and Brown people, continue to face daily discrimination. And some of that's the hard to prove stuff, like around employment and housing discrimination, as we all know. And sometimes that discrimination, unfortunately, comes at the hands of the people who are most supposed to protect us, most supposed to support us when we're down and out. Trans and non-binary people are threatened for using the bathroom, harassed when they're doing something as mundane as shopping for groceries, beaten or murdered, unfortunately, especially for our Black and Brown trans women, simply for being trans and existing in our world. The other group who I think are really needing our help right now and are on the frontier, so to speak, of queer and trans justice are our young folks. So LGBTQ young folks, I think, are in a particularly dangerous time. When I came out 20 years ago last month, I didn't have the internet. You know, there weren't as many books. I would sort of go through Barnes and Noble and there was that shelf, and I would secretly like hide behind the religion books to try to see that shelf. Well, now 12-year-olds can access the internet and get that information about the language they need to self-identify so much earlier than previous generations. But we as a society aren't really prepared to accept and support those 12-year-olds who are coming out as trans, or that 14-year-old who's coming out as pansexual. And so they continue to face things like high rates of bullying and discrimination in school, regardless of the laws and the policies designed to support them. And part of that is because teachers don't know what to do. School counselors don't know what to do to end the bullying. The faith communities, unfortunately, there's still a lot of faith communities that are attempting to change sexual orientation and gender identity, which can lead to a lot of self-hatred or lack of self-acceptance, among other things. And I read recently a report out of the Trevor Project, says that only a third of young people who are LGBTQ identified have supportive parents or guardians. So that means that 2/3 of kids either have unsupportive parents or are hidden at home, both of which are really difficult circumstances, particularly in the midst of quarantine and isolation. And those young people are far more at risk for depression, anxiety, suicidal ideation, and as we talked about earlier, homelessness. I want to make a note here that for LGBTQ youth who have supportive parents, their risk factors are almost indistinguishable from their straight cisgender counterpart. So this is not something that's part and parcel of an identity. It's really this experience of being rejected within your own home. And so Pride, again, is that important chance to throw off the shame of rejection and that daily experience, sort of grinding experience of minority stress, and be surrounded by people who share our experience. It's a time when we can simply be. It's also a time to remember our history, to look back at where we've come from, and to look forward to our future of liberation and hero or love. And one of the reasons that's so important to me is because it roots us into a legacy. It reminds us of our heroes, and it tells us stories of overcoming. And I think every culture who's experienced these challenges relies on these stories of overcoming to bond to one another and to bond to the strength of that experience of overcoming. And an important milestone in queer and trans history is the Stonewall riots. So Stonewall Inn was a bar where LGBTQ people were welcome to gather and party and find friends. And in June of 1969, when there was a lot of protesting going on around the Vietnam War, women's rights, civil rights, the police decided they were gonna raid the Stonewall Inn again. This was a routine thing at a time when intimate relationships between gay and lesbian people were still illegal. And it was illegal to dress in ways that were inconsistent with your gender. And so folks were routinely arrested at this bar. But this night in June of 1969, the patrons weren't gonna have it, and they resisted, led primarily by Black and brown transgender women. They resisted arrests, and they started to fight back against the police. They threw bottles, they threw bricks, they even uprooted a parking meter and threw that at a police car. And those riots lasted 3 days with many of the same people at the front lines day after day. And that was the birth of the gay liberation movement. That's where all of these marches and parades we have today come from. It was a month after those riots that New York City had its first gay liberation march, but this wasn't a parade, this was a protest. And people then, listen to this, people then were protesting for the right to live free of harassment and violence at the hands of the police. I think that resonates pretty deeply with us today, right? And it only seems appropriate to talk about this. 51 years later, our streets are full of people living for the right to live free of harassment and violence at the hands of the police. In some ways, it can be so disheartening to see how little progress we've made, and yet, for me, there's great hope. People of all ages are turning out in droves. There's energy like I've never seen before. And this morning, I want to share that I saw images of thousands of people standing outside the fences of the White House singing "Lean on Me," right? I saw a video of protesters encircling a group of Muslim protesters so that they could have their midday prayers peacefully. I see people courageously stopping the destruction of property, stepping into the line of fire to care for wounded strangers, and people of all ages, races, and ethnicities coming together to express this hope for a better world. And this is relevant to Pride Month because the LGBTQ community is diverse. My queer and trans siblings are Black and brown. And because we know that when we create a community where the most vulnerable people can flourish, all people can flourish. This Pride Month, we won't be gathering for a parade because of the coronavirus, but on Saturday, we will instead be on the streets wearing masks and marching behind signs that say Black Lives Matter. The future work of the queer and trans justice movement is intersectional. So it recognizes that our flourishing is connected to the flourishing of one another and to the wholeness of everyone. This is who we are as a queer and trans community, and it's who we're growing into more and more over time. And so the hope is the resilience I see, the unity I see, the perseverance and the love between people that I see. And that's why we have young people who come out even though they know they're going to be bullied. It's because they're not alone. They belong to a larger community of people. And that's why we have Black and brown people who live in their authentic gender, even though they know they're likely going to face discrimination and maybe even violence. It's because they know they're not alone. They belong to us. And Pride is that time every year when we gather together and remember who we are and celebrate who we are. Remember our heroes and look forward to the future. And so I'm just really grateful for the chance to come and share with you all today. I'm grateful that your coalition has made space to talk about Pride Month and to honor it today. So thank you all so much for having me. If you have any questions about Pride or about supporting LGBTQ young people, please feel free to reach out. My email address is Paige, spelled P-A-G-E, at NWYS.org. How was that, Terry? Do you need anything else from me?
That was great. Thank you so much. Really
All right,
appreciate
thank
you
so
being
much.
here.
Yes, all right. Well, happy Pride Month, everyone.
Thank you.
Thank you. Bye-bye.
Bye. Okay. Next up, I think we'll start our panel presentation on health and homelessness by Jen, Erin, and Jennifer. So we can make sure that everyone has time to present. Barbara and I were thinking it would be great if you could put your questions in the chat box and then we can ask those of the presenters at the end. Jen, would you like to start?
Sure, I can go first. Can you guys hear me?
Yes.
Good. That's step one accomplished. It's nice to see you all. I'm sorry you can't see me. That's not intentional. I just can't figure out how to do video and audio at the same time, even after all these months. I have a real brief PowerPoint, so I was going to try to share my screen. I'll see if that works. Yeah?
Yeah. Thank you.
All right, woohoo. So thank you for having me. I appreciate the opportunity to talk with you all. I'm the social work supervisor at St. Joseph Hospital. I've been at the hospital for 16 years, mostly in the emergency department, but I've worked all over, been in the supervisory role just the last 3 years or so. And so to start off, I thought I would just let you, talk a little bit about what the social workers do at the hospital. We're in a really unique position to interact with unsheltered folks who are medically fragile or have mental health and substance use issues going on. We see everybody from birth to death and everything in between, with every kind of issue that you could think of. So in the emergency department, there are social workers, mostly in the ER. What we're doing is mental health evaluations for folks who are in psychiatric crisis. So out of the emergency room, some of the resources that we might use for folks that are homeless and need assistance. Of course, we use the drop-in center a lot and coordinate with them. We use crisis triage and detox quite a bit, inpatient psychiatric facilities. And then another resource that we have that's unique to the hospital is we actually have beds that are part of the Lighthouse mission that are medical respite beds and are for people who either have a new injury or need like an extended period of recovery, but they don't qualify for a nursing home. They don't need that level of care, but they can't really just be out on the street. So there's a bed at Agape and a bed at the mission for men, and we can use those beds for people. And then we've got social workers that work on the medical floors. So we have 8 different medical units in the hospital. And there's social workers on all those floors, and we're doing discharge planning for people. And, you know, when we have homeless individuals who are medically fragile, sometimes it may be they've been homeless and kind of living marginally for a long time, and they just, you know, they've had some event that's brought them into the hospital. It's just the last straw, and they really can't go back out to the street. So we're trying to help place them. Or it might be a homeless individual who was previously quite independent and doing just fine, and then they've had a stroke, or they had a, you know, some kind of major traumatic event, and now they need a different level of care. So that's a pretty lengthy process for us when we are trying to rehome somebody or home somebody in those circumstances. Oftentimes we have to get funding secured is the first thing, and we have to help people get Medicaid. That can be complicated. It's also a lengthy process. And we're working with Home and Community Services to get an assessment from them so we can get people into like an adult family home or assisted living, those kinds of things. So that's a big role that the social workers play here at the hospital. I'm just looking at my notes for some of the other things that we use. So of course we have, most of you probably know, we have PeaceHealth has a hospice house. So we do use the hospice house for folks who are end of life. There's no, you know, there's no issue or no, you know, if somebody was formerly homeless and they need that, then if that's appropriate, we can access the hospice house. We interact with the HOT team in all of these domains, actually, you know, on our psych unit everywhere. We work pretty closely with the HOT team. And then we have another resource option that we have for folks with medical concerns, homeless, and need next level of care is down at United General. United General is also a PeaceHealth facility, and so they have what they call swing beds, and they're a nursing home level of care bed that's actually in their hospital. Unfortunately, we don't have those up here. It would be really great if we did, but they have them down there. They actually have 15 swing beds, so we can refer folks down there who just need, you know, a few weeks of rehab, and then can potentially, you know, go back to their former situation. And then on our inpatient psychiatric unit, you know, we've got a whole different arena that we work in. We use Lake Whatcom Boarding Home a lot in normal circumstances, and we use their S beds, their shelter beds. We are sometimes working with Compass Health to access their residential treatment facilities in Everett, in the Snohomish area. Quite frankly, it really is quite sad that there are not more options for residential treatment for folks with mental health issues. There just are not. Western State Hospital is pretty much not an option for us at all. I would say it's probably been over a year since we had somebody go there. The wait list is just so long, and really they're moving away from taking folks unless they need forensic evaluations. So it's something I wish, not Western State Hospital necessarily, but I wish there were more options for residential treatment for people with mental health issues. And then we also use Northwest Youth Services in the PAD, sometimes even out of the emergency department, we can get people in there. And then let's see, finally, we've got the Childbirth Center for individuals who are homeless and have just had a baby. We, of course, use Lydia Place, which I know we're going to hear more from them. So those are some of the places where social workers work and some of the things we're doing. Let's see, I tried to follow your outline a little bit. So I have some organization. You asked about, there are some questions about what are some of the barriers that we face. We face a lot of barriers, you can probably imagine. For one thing, you know, people typically, right, are supposed to be in the hospital for a short period of time. You're not supposed to, this isn't transitional housing, right? So that's a huge barrier, is that somebody's medical issue may resolve within 2 or 3 days, but then the discharge plan piece takes a lot longer to get through. Some of the barriers that we've had more recently related to COVID are around quarantining. Different facilities in our community and even outside our county don't want to take people into the facilities unless they've had a 14-day quarantine. So that's been challenging. It was challenging when this all started. Facilities wanted testing done before they would take people, and there were so many parameters around testing that we could not always do that. I'm happy to say that that is no longer really a barrier. We can test people going to a nursing home, we can test people going to an assisted living, going to a psych unit, going to detox, going to triage. Our testing capability is much better than it used to be. And then I don't know how many of you know about the isolation and quarantine facility. Probably most of you do. That's the Motel 6 on Byron. That's been stood up just since COVID, working closely with the health department and the GRACE program through CMAR and the Lighthouse Mission. And the PeaceHealth social workers actually have been doing like the bed control for that facility. And I would envision, hopefully we won't get to the point where we need more facilities, but if we do, that's a role that PeaceHealth is allowed us to play, and I'm grateful for that, to be able to be a part of that. Y'all can still hear me? I feel like I'm talking to myself a little bit. Okay, good. And then barriers that aren't related to COVID. Folks just with more than one issue, with co-occurring issues. If you've got medical issues and mental health issues, it's an issue. You can go to a nursing home for your medical issues, but they don't, people, if they have acute psychiatric issues, then that's a problem. You can go to a psych unit for your psych issues, but you can't go there if you have overlapping medical issues. Co-occurring between substance use and mental health, it can be an issue. So that's a barrier. Like I said, funding is a huge barrier. We're not talking generally about people who have a lot of money to private pay for, right, to go to a facility or whatever. So folks, we usually have to help them apply for Medicaid, or at least apply for the long-term care benefit of Medicaid. And it's complicated. We do all kinds of creative detective work to get people's, bank statements, to get people to meet their spend down, all of these kinds of things. And it can often take 30 to 60 days just to get their Medicaid application approved. And depending on the circumstances, sometimes those people, people who are very vulnerable and in that position and need placement, then we will keep them in the hospital so that we can help make that happen. Challenging behaviors are a barrier for nursing homes. For everywhere. People with dementia who are wanderers, people with drug use histories, people, just various behavioral things going on are definitely a barrier for housing or for moving people to the next level of care out of the hospital. There's a lack of facilities, especially in Whatcom and Skagit County. There's a huge, like I said, for mental health, but also just adult family homes, assisted living facilities. Most of them are private pay, so they don't cater to, a more vulnerable population. Lots of times when we have to place people, we actually have to look in Snohomish County, which is unfortunate if they have connections here or family here or whatever. So that's an issue. And then finally, there's others, but the last one on my list anyways is decision making, or people not being able to make their own decisions and not having any kind of a surrogate decision maker in place. So that often is related to folks who have cognitive impairment and worsening dementia and have been living on the street, and they're in the hospital for whatever reason, and those folks it's just challenging, as you can imagine, all the way around. Figuring out their medical course of treatment, of course, and then just that moving people to the next level of care. If they don't have competency and they don't have anybody to make decisions for them, that's really hard. And every once in a blue moon, we pursue guardianship for people, but that is also, it's not so much an expensive process as a really lengthy process. We had a gal we pursued guardianship for a couple of years back, and it took 2 years to get a guardian in place. So it's not a quick fix at all. Let's see, you asked about additional challenges that we're seeing just due to COVID. I mean, as you can imagine, these 3 things that I list here, they kind of all go together. There's this lack of normal face-to-face contact, and people seeing their case managers, people seeing their providers, people seeing their families, etc. And so you may have heard, you know, that there was a real dip in our volumes here at the hospital. Actually, for a while, people just, you know, I think just in general, people were staying away. People have been isolated, and so mental health conditions and medical conditions were not getting treated, not getting attention. People were just kind of holding up, and so now we're seeing a real resurgence of folks who are pretty sick, both from a mental health and a medical perspective, and a lot of people, including probably a lot of people that, you know, we all interact with every day, just in our personal lives, that there's this sense of heightened anxiety and depression and whatnot. A lot of things going on in our world. Let's see, you asked the question, you phrase it as, what are the primary needs upon discharge that agencies, case managers, and government can support? And these are just some of the things that I thought of. There's probably others, I'm sure, but having conversations with people about their advance directives and who they would want to be surrogate decision makers is obviously important for all of us, but I think it gets overlooked in, you know, so something to keep in mind. We see a lot of folks that, you know, folks come in, they had Medicaid at one time, they lost it because they didn't get the letter, they didn't turn in the document, they didn't do their follow-up phone call or whatever. So if case managers, folks in the community can help people to be keeping an eye on that, whether it's applying for Medicaid for the first time if they'll qualify, or just making sure that they don't lose it, that's very helpful. Home and community service referrals or Northwest Regional Council, you know, those are the 2 agencies we use when we're looking for placement for somebody, for caregivers. You're probably all familiar with the GRACE program. We work very closely with them, and I find them to be an amazing resource, very helpful. And they often will keep an eye on or coordinate some of these things that I'm talking about, like getting a POA in place or getting the Medicaid application started, those kinds of things. So the GRACE program is great. And then the community A team, that's once a month, just a sector of folks from the community that come together to talk about individuals. It's really a problem-solving forum. So individuals that are, you know, the collective minds can kind of work together to try to problem solve some things that might help them. So that's another resource that we use. And then there was a question just about policy needs. And this is actually near and dear to my heart. I was fortunate enough to be supported by PeaceHealth to go to Olympia in January. I went down with some folks from Vancouver PeaceHealth Southwest and lobbied. It was during the Washington State Hospital Association Advocacy Days. So over 2 days we lobbied for all kinds of different things. So I spent a lot of time thinking about this. And these are some of the things that we did advocate for a streamlined process for Medicaid, increased funding for Medicaid. That's often a huge barrier for us, and why a lot of the facilities only want private pay is because Medicaid doesn't pay enough. So advocating for higher Medicaid rates for placement, like I mentioned, residential placement for folks with mental health and or substance use concerns, and the home and community service referrals. And then lastly is another topic that is that I feel really strongly about. Like I said, we have these 2 medical respite beds that we use at the mission, but it's not nearly enough for what our community needs. We have, homeless individuals. The drop-in center is going above and beyond and doing amazing things to help people, but our vision is really to have a broader respite kind of facility, and that, yes, that people could discharge from the hospital, but that they could also just go into, I guess, from the drop-in center or whatever. Again, that don't need maybe nursing home level of care, but they're medically fragile, that's staffed 24/7, that people can get some personal care if they need it. They can get help with medication administration, those kinds of things. And I don't know what people know about that, but there's quite a bit of talk in our community about making that happen. So I am hopeful about that. You got all that memorized? That's us in a nutshell.
Thanks so much, Jen. I just really appreciate you being here and sharing this information. And I know that staff at the Service Center see a lot of these needs as well, and really gaps in resources.
Yeah.
And
I appreciate you having me be part of the conversation. Thank you.
I just also want to mention that Mike Parker in the chat announced that Opportunity Council is in construction on a new recovery house for residential treatment of folks with co-occurring disorders, due to open this fall. So hopefully there's a new resource there on the horizon to ease some of the demand. Thanks very much.
Yeah.
Erin, would you like to go next?
Sure.
Great, thanks.
Let's see.
Do you need to share your screen?
Yes.
Okay, you should be able to go ahead and click the bottom of the screen where it's in green that says share screen, and then you can select what you want to display.
Yeah, I somehow just got like accidentally out of, yep, there we go. Okay.
Okay.
It says I have to wait till, till she's done sharing.
Oh.
Is that good?
Okay, you're good.
Okay.
Thanks, Jen.
Phew.
All right, and I know you've got a lot on your agenda, so I will try to pay attention to time. You asked for about 10 minutes, so I will just pick out a few things. So my name is Erin Smith. I'm the clinical director of the mental health program at Lydia Place, and I'm going to apologize in advance. I have a 2-year-old and a 4-year-old, and I'm pushing my limit with them here, going on 45 minutes. Okay, go ahead. Put your shoes on. Sorry, trying to focus. So I'm the clinical director at Lydia Place. It's a mental health program, and our mental health program has been around really kind of in full existence since 2017. And a lot of people don't realize that we actually are doing clinical mental health. So currently we have a team of 5 clinical mental health providers. And so we were created in response to this huge gap that we all know exists for those that are experiencing homelessness and need mental health support and aren't able to access the supports that do exist that aren't enough, and there's just a lot of barriers to accessing those services. So at Lydia Place, we kind of worked for a couple of years on developing a program that can meet the needs of those that are in our program. So I apologize again.
Don't worry about it. I had to take my screen off so I could let the cat out earlier. So we've all been there. It's okay.
I had like 45 minutes of silence, and then it was like immediately when I came to talk, they came running in.
Of course.
So the barriers that we were seeing to people accessing mental health, which I'm sure many of you all are familiar with, are just sort of the inflexibility of systems to be able to respond to people whose lives are in chaos and may not have working phones and may have a challenging time making and keeping regular appointments. People that have just a lot of anxiety that prevents them from using public transportation. People have children and no support systems, and many of our systems are not set up to allow children to come to appointments. And so if, you know, a lot of the folks we are working with who are experiencing homelessness don't have any safe childcare, and so they just can't get the mental health that they need. Of course, stigma, which we all see, and then just a lot of folks have had experiences with mental health systems that have not been not okay, and that has prevented them from wanting to return back into a system where they felt judged or unheard, or pushed into things that they weren't ready for, didn't want. And so due to all of those reasons, we created this program, and so we reduce all those barriers as much as we can. So we go to people where they are. So we're in their homes if they're in homes, we're in their hotel rooms if they're in hotel rooms, we're on the street if they're on the street. We have some partnerships with the shelters, Agape and WCCEH, and so we will provide mental health services in those spaces. And we're different in that we're not doing, we're available for some crisis intervention, but primarily we are regular, ongoing, long-term or short-term mental health therapy for those folks that are currently or recently experiencing homelessness. And so our team, in addition to providing direct services, and we just recently expanded to, we were seeing just adults, and now we've expanded to see teenagers, just because that was a need that we were seeing, and we were getting a lot of requests for kind of the same reasons that parents can't access mental health services. Often the same parents are having teenagers that can't access for all the same reasons. So we've expanded to be able to serve that population as well. And so in addition to the direct therapy that we provide, we also provide a lot of training and consultation to the other staff within Lydia Place. So making sure that our case managers, our parent support program, and other programs as well in our community that request it, to help people better understand mental health struggles, kind of some tips and ideas for working with particular types of mental health challenges, and then just to be able to consult with people. So not everyone wants mental health services. We have found that a lot do when it's offered, and it's flexible and it's meeting them where they're at with really, really low barriers. A lot do want our mental health services, but those that don't, we can then just support those other providers that are working with them to bounce ideas off of, or things like that that can be helpful for clients. So how we've adapted to COVID-19 is we've switched completely, as probably everyone else here, to telehealth. And we were a little worried because we expected actually that most people would have a hard time, would not want to transition or couldn't transition. And probably about 60% of our clients have transitioned to video services, which is awesome. And then the others, with a select few that we've kind of have dropped off completely, we do phone sessions for a variety of different reasons. I think I already addressed barriers, and the increased barriers that we're seeing to people accessing mental health during this time is children at home. So whereas before, if children were home or younger children, we would go there and it was a little bit different than obviously when you're sitting in front of a screen, and that's super interesting to all of your children who are hooped up and so we also, when we're going into homes, we sometimes will bring someone to assist with childcare or play with the kids while we're doing therapy, and we can't do that here. So that's tough. So we've seen a lot of people that still really want to engage, but the level of engagement is different. And people are overwhelmed with responsibility of schools, childcare, work. So while people have, while people often are keeping appointments and wanting to keep, so they want to keep appointments, and often as mental health therapists, one of the barriers to kind of digging in and accessing or working with people on trauma is kind of that there's crises of the week that happen, and so you kind of get stuck in these patterns of trying to help navigate current crises, and so you're always sort of waiting for this time when things are not in such crisis mode. And to some degree that is happening now, because people are not out and about. There's not the same sort of crises, but people lack the emotional capacity really to kind of dig in to those things. So and then of course technology is a struggle, and so we're just sort of trying to work with that the best that we can. You saw them. And just as Jennifer mentioned, during COVID-19, we're absolutely seeing worsening symptoms for a variety of reasons. People are isolated, people are anxious, just like the rest of us, people are overwhelmed. For a lot of folks that we've seen in our program, you know, if people have been engaged with us for a while, they've been really setting some goals and working towards those goals and seeing progress, things like getting ready to start school or just finally got a job, and then and that could have been years of leading up to that, you know, starting with being on the streets to finally getting housed, and then all of a sudden it's the rug is pulled out from under people, and that's really hard to hold space and to be able to validate those struggles for people. We are seeing substance abuse relapse, and while there are supports that exist, they're different and they're not as accessible to people, and so we know that a lot of folks that previously struggled but maybe were on a strong path and had some good recovery supports in place have had some relapses and setbacks, and then also we know with this and people being stuck at home, there's a lot of additional stress and tension in homes, which sometimes leads to increased violence, so we sort of are hearing, we are not currently seeing a lot more referrals or people, because I think people are sort of waiting in hopes that this will be over, but we are expecting, as is kind of our state and our nation, that the need for mental health is going to increase significantly, and the demands, which already outweigh the existing resources, are going to overwhelm the mental health system. So that's kind of what we anticipate. As far as unmet needs, I kind of feel like I could list them forever, but generally, you know, all of us are in some capacity working with those experiencing homelessness, and so those in our programs are not, you know, they have the same unmet needs that everyone else here is seeing. But you know, there's a lack of children's mental health, struggles with childcare, lack of access to healthcare, even though the healthcare exists. Sometimes actually accessing it is really challenging. of course, social supports are a challenge for the folks that we serve. And perinatal health care, which you had asked me to address at some point, how we are working with perinatal health care. But that's a struggle often for families that we see, is not being able to access or not being willing to access the existing prenatal care in our community, and that there's not a lot of people who specialize in mental health for those in the perinatal during pregnancy and after pregnancy. So it's about 4:30. Should I stop so I give others a chance to continue with the agenda?
Sure. Yeah. And I just want to, I appreciate you doing this. And it's challenging working from home. I think we're all challenged. So I appreciate your flexibility and resourcefulness. So yeah, if you wouldn't mind staying, I know that Barbara and I have some questions for the panel at the end as well. And so Jennifer Moon, are you ready to present?
Yes, and I'm going to try to share my screen. So,
I want to, while she's doing that, remind folks, if you have questions or you think of questions, please put them in the chat box and we'll be sure and ask at the end.
okay, are you seeing it? Slideshow?
We see it.
You're great. Okay. Okay, I am Jennifer Moon, Communications and Public Relations Associate with Unity Care Northwest. And first of all, I was asked to talk about the role of Unity Care in working with our patients experiencing homelessness. And I'd say there's two roles. The first is that we are a safety net healthcare provider. So we are a nonprofit, federally qualified health center, which means that we receive some federal funds to provide access to medical care for those who may be unable to pay or uninsured. So we provide access regardless of income, ability to pay, or insurance status. And our approach to care is whole person care. So we provide integrated primary medical, dental, behavioral health, and pharmacy services. And we have two locations in Whatcom County. We have Bellingham, and then we have a new health center out in Ferndale. So as I said, our approach to care is coordinated care for the mind and body. And one of the things that we find really helpful is that we're able to, by being able to collaborate, our providers can, for example, our dental providers can work with our medical providers, so that if there's a condition, a medical condition that affects oral health, they can both work together on that problem, or vice versa. Our pharmacists can work with our medical providers to try to avoid, and our behavioral health providers, to try to avoid harmful side effects of various medications. So there's a lot of ways that we can try to improve the health of the entire body and improve health outcomes for the patient. We also have on-site case management and embedded behavioral health in the clinic. And we also have a population health program that we started last year. And I think I saw Katie Stevens on the call. She is our new patient engagement supervisor, and she's part of that program. That is a program that we're part of the role of that program is to work with patients with chronic conditions like diabetes. So for example, some staff in that program have started a VeggieRx program, a fruit and vegetable prescription program, which identifies and engages patients with uncontrolled diabetes. And we're doing this in partnership with several organizations, the Bellingham Food Bank, PeaceHealth, CMAR, and the Community Food Co-op, and also the Community Health Plan of Washington, to try to improve patient outcomes and simultaneously lower the cost of treatment of diabetes. So that's one way where we're trying to look at a group of patients and move the outcomes of the entire group. We try to bring healthcare outside the four walls of the exam room. So we have some community health workers. Laura Reardon works with our patients experiencing homelessness, and she's out in the community providing a holistic approach to reducing barriers and increasing access, trying to connect people to care, also working on insurance and addressing basic needs. She can also provide a warm handoff to our behavioral health staff, our case managers, and our medical team. And then we have two other community health workers at St. Joe's who work with some of our patients who frequently rely on the emergency room to try to connect them to primary care. Last year we started a program at Carl Koger Elementary where we have a behavioral health counselor who works with children and families on site, providing mental health counseling to the students there who are not able to access services otherwise, and also providing a resource for their parents who might have work or transportation challenges. And then again, also providing care within the school setting, but providing a resource for connecting them to ongoing care at our clinic. Our mobile dental program goes out to all the elementary schools and middle schools and some of the high schools and daycare centers across Whatcom County, providing dental exams to the kids in the schools, and fluoride and sealants, and just also, again, providing access to people who wouldn't otherwise be able to get oral health care. And then because of COVID, we'd had plans to start doing prescription delivery, but we accelerated that. So we are now out delivering prescriptions for our patients who use our pharmacy. And then, as others have talked about, we've really ramped up telehealth. Our behavioral health program, I think, is at the same level of service they were before. They've been really successful at transitioning to telehealth, and then our medical teams have been doing some of that as well. So that's the first role, is to provide care. And the second role is really an advocacy role. And that kind of is generated out of the mission of community health centers, which really started in the 1960s as part of the war on poverty. And we started as a means of connecting people who otherwise did not have access to healthcare to the services and the care that they needed. So that kind of advocacy is really at the forefront of the health center movement. And so we take our advocacy role pretty seriously. We work with our legislators pretty closely, and we advocate for policy change, around equity, about treating and preventing trauma and toxic stress, and also it's really important for the community health center movement, as well as other healthcare providers, but to really advocate for a culture of prevention, that we're preventing illness and chronic disease rather than just treating it. And so we work pretty closely with a number of community partners in areas that align with building the conditions for health. And we talk a lot about why is being healthy so hard, which is what we would typically think of as the social determinants of health. So things like food insecurity, poverty, education, employment, and obviously housing. Housing is the foundation for health. It's associated with safety, sleep and nutrition, social relationships, stress and anxiety, and hygiene. So we sit on several steering committees and various work groups to try to help support the work of other organizations in the community, but also to be an advocate for policy change in those areas. So barriers to service, one is lack of trust. fear of what to expect. We really saw this when the Affordable Care Act was first passed, and patients who had typically relied on the emergency room, that was what was comfortable for some patients, and so trying to create a connection to primary care was one challenge. But just generally, healthcare is a big industry. It's not easy sometimes to navigate, and so that's one of the roles of our community health workers, is to create those relationships out in the community to try to connect people. Competing priorities, getting to a medical appointment may not be as important as finding shelter and attending to basic needs. So that's definitely a barrier. Lack of transportation, behavioral health services, and again, service navigation. It can be confusing around insurance issues and making and getting to appointments, dealing with referrals, and also I think self-advocacy, learning how to communicate with healthcare providers and advocate for the patients, what are the patient's goals. And finally, treatment versus prevention. So I think many people think about healthcare as, I go to the doctor when I'm sick. And we absolutely want to be there when people are sick, but we really want to work with them before they get sick. So I think trying to move people towards that orientation towards prevention. So then there are all the additional barriers related to COVID. So hand washing and sanitation. We're now masking all of our patients and staff as they enter the clinics, practicing physical distancing. Obviously, those people with chronic health conditions are more vulnerable to disease complications. There's additional stress and trauma that's been exacerbated by this. Some of our patients don't have phones to participate in telehealth, so that's been a challenge. And just the ongoing certainty kind of adding to all the other uncertainty. One additional challenge is that there have been challenges with our patients being able to access the supportive services and case management that they typically have relied upon in the community, just because we're all working from home, and so the uncertainty around that has been a challenge. And places to stay during the daytime. And one other thing is we had to close our bathrooms because again, we're screening everyone before they enter the clinic. They're being asked to hand wash and sanitize and wear a mask. And we had always people would just come in and use our restrooms. And so that's obviously now much more of a challenge. We're now kind of trying to turn our attention to returning to normal. The first month or so was pretty crazy, but we're now kind of moving into phase 2 of thinking about, okay, what are the systems we need to have in place to get back out into the community, have our community health workers do health education, perhaps help with contact tracing, and possibly with mask distribution out in the community. And then finally, unmet needs, obviously housing, expanded behavioral health access, and then hygiene and medical respite. So I can follow up on what Jen started out with on this topic about the need for medical respite and the conversations around that. We've been in conversation, we've been working with the Opportunity Council and PeaceHealth and Whatcom County on what we're calling the way station, which would provide medical respite, showers and laundry facilities, and then primary medical care. And we're working right now on nailing down a location for that. And then we are going to be moving in the very near future towards trying to secure some funding for it. So that is moving forward. And we're pretty excited about that. So I think that would be a great resource for the community. So, and that's all.
Thank you so much. I think the thing that this whole presentation is really driving home, and this is something we've been hearing for years, but healthcare, housing is healthcare, and nothing like COVID-19 drives it home quite like that. And also, talking about the challenge of getting technology made me think about the outreach team reporting that now that so many businesses are closed, people have difficulty getting their technology charged even if they do have them. So that's another barrier to services that we're seeing in the community. Not seeing any questions in the chat box right now, but I do have some for the panel. To start out with, can you offer any suggestions how health centers and supportive housing providers can work together and on their own to identify and address disparities in advance health equity? Does anyone want to take that one?
That's a
Hey,
big
could you repeat that?
Yeah.
It was a toothy question. Looking for suggestions on how health centers and supportive housing providers can work together or independently to identify and address disparities in advance health equity. That's a big question.
Well, I think we, again, I point to the advocacy role. I mean, that's what my part of my job is. So I kind of gravitate towards that. But I think that we do collaborate in terms of, and there's more opportunities to do so, to reach out to legislators and policymakers and community leaders to talk jointly about these issues. I think that if people are hearing the same message coming from multiple sectors, I think that's really powerful. And so I think there's a lot of opportunity there.
Thank you. We've got a question from Joe Gibson at Compass. For Erin, how does a person access services and what type of insurance?
So for our programs, most of who we serve comes through our housing case manager. My mom. So it's literally it's a one sheet of paper that has just basic information. Yes. Okay. Just a second. So we have a really basic referral form. So often people have been talking to folks about counseling, and that can take months sometimes to get people to a place where they're ready. And then it's a referral form, and then we have a conversation with them about the best way to do a warm handoff if possible, or should we cold call, or kind of what's going to lead to the best way to initiate engagement. And so that comes from us, or from those that we partner with, same thing. It's just a one sheet, really easy referral. We do take all Medicaid and Medicare, but we're really not, taking insurance is pretty new for us. So we actually primarily were not billing people at all, or billing anyone for a long time. And so we're new to it. So we are not in any way dictated by insurance companies or any of the restrictions. So when we can, we bill Medicaid or Medicare, and when we can't, we have other funding to support that. I want to stay with you.
It's Jen. I was just going to say something about the question about addressing health disparities that you asked, Terry. And I feel like our community is making strides in this direction, but I just feel like we have to be so creative about, people have so many barriers to going to a certain appointment in a certain place at a certain time. I just think as a community, we have to get creative about how to, meet people literally where they are with what what they need. And there's various ways I see that happening, but room to grow.
Thank you. There's a few more questions in the chat box. I'm starting to get a little concerned about time. So I'm thinking that I would like to email the rest of the questions. Would that be okay, and share out with the group later? Would you be willing to do that? Okay, great. Appreciate that. Next on our agenda is a county update from Barbara.
Hello.
Hi, Barbara.
Hi. Good. You can hear me, so that's great. Well, I had I'm going to reduce my updates by a lot. So very quickly, I think the most interesting points of my update have to do with new funding coming into the community. And this new funding is from a variety of sources, all related to COVID-19. So, and some of the funding we have not yet received, so it's uncertain that we will actually receive what we're being told we'll get. So I'm just going to run through the various funding types, and that will be enough for now. So the Housing and Essential Needs Program, we're going to see a $600,000 additional grant coming from Commerce, and that serves people who have disabilities and also experiencing homelessness or at risk of homelessness. This will serve quite a few additional clients, and will also be able to be used to extend some current recipients of HEN for July through next June. This grant runs. Because it's such a large grant, we will also need to add some staff capacity through the Opportunity Council to be able to get those funds out. We also have the CARES Act funding, which is coming into the county to cover the county and all the small cities and Bellingham. And that funding is over $16 million. That is related to the public health response for COVID, of course. And about 15% is going to be used for human services. Other funding will be used for economic security efforts, child care support, and other uses. This funding has to be spent out by the 31st of October of this year. So we have to move fast and furious in getting it out. We're assuming about $600,000 of that fund will be used for rental assistance and mortgage assistance. And that is going to be for people or households impacted by COVID that earn up to 80% AMI, and some of whom have lost their jobs and may not have any income whatsoever presently. So planning efforts for that funding are still underway. And then we expect to receive an emergency solutions grant from Commerce that will start July 1st. The estimate of funding coming into the community from that is about $400,000 to $450,000. And this is similar to other funding that we receive from Commerce, referred to as the Consolidated Homeless Grant. However, ESG, the Emergency Solutions Grant, is a federal grant that's passed through by Commerce to the counties. And I just got off a call with Commerce prior to this meeting, and Ted Keller, who is the manager or director of Commerce, their housing assistance unit, is anticipating that Washington State will receive a higher than normal allocation for ESG funding. The reason being that we have a high number of unsheltered folks in our state, and the grant is being distributed accordingly. So we will be able to use that for a number of different intervention types, such as rental assistance, case management, paired with that rental assistance, shelter, and outreach. And then we also have new shelter funding coming to increase our bed capacity from Commerce. And there's a draft proposal for this shelter grant on the website of Commerce that you can comment on if you'd like. We have diversion funding available for a limited number of counties throughout the state, and that's going to be awarded by competitive grants. There will be a focus on equity and serving high-risk populations through coordinated entry. And we also have received additional home consortium TBRA funding. This is rental assistance, and this was passed through to the Opportunity Council from our Skagit Home Consortium. So this is HUD funding that we had actually intended to use for affordable housing, but a small portion of it was set aside because of the COVID emergency for the 3 counties in that consortium. And that is all. Any questions? Feel free to send me an email.
Barbara, Katie Stevens has a question. Is the ESJ new to Whatcom, or is this a renewal?
That is not a renewal. We had previously received ESG and have not received it for a few years. And so that will be a brand new grant. However, we're very familiar with it, and it will be fairly easy to roll out, I believe. The difficult part is knowing how to use it and to plug all the gaps. And at the same time, we do anticipate that document recording fees may be reduced due to the economic impact from COVID. So according to Ted Keller, who I was just referring to from Commerce, he also indicated that the document recording fee reductions may certainly be helped by this ESG grant. So that is some good news to report. I think at the end of the day, we'll be lucky if we're able to maintain our housing budget through the county, at least throughout this COVID crisis. But time will tell.
Yeah. Thank you, Barbara.
You're welcome.
Samia, could you give us an update from the city, please?
Hi, yes, thank you very much. Kind of just dovetailing on what Barbara was talking about, the city is also working on allocation plans for some of these additional funds. We received additional community development block grant funding from the federal government, which is similar to what we get every year, but a little bit of a boost, about half in addition to what we typically get. And that funding can be used for human services, type assistance, food, that kind of a thing. And we've also proposed our council and more revenue dollars on housing security as needed. We've already done to some degree, starting in March, right at the beginning of the COVID outbreak. Our annual action plan will be going to City Council on Monday at the City Council meeting. And so they will be deciding how to move forward at that time. We're also in close collaboration with the county and the Lighthouse Mission, kind of looking for more longer-term stable locations for folks to be after the school district is required to take that building back. So definitely keep everyone posted on that progress. And that's it for me.
Thanks, Samia. It was a little bit, I don't know if it's me or you, but it was a little bit hard to hear. It sounds like you were talking about working on the drop-in center relocating from the high school to another location.
That's correct, yes. Just collaborating closely with agencies about that, but we don't have any certainty at this time.
Thanks, Samia. Appreciate it. Before we close, there's 3 minutes for public comment. So if anyone would like to share, go ahead and unmute yourself and let us know what you'd like to share. And hearing none, it's about
Terry.
time. Yes.
I just wonder if Mike could give his spiel that he didn't get to give at the beginning.
I don't know that he
Is he
recovered
here?
audio. He's here.
Oh, okay.
Sorry, my cat is walking past the camera. Okay, I'll read from Mike for those of you that can't see the chat. Oh, there you are, Mike. Sorry, I have a kitten. Mike says, it was good news that the doc recording fees have not tanked yet. Good to see you all here at the coalition. Sorry, my audio was bad. Here's a brief synopsis of my job. As Terry said, housing is healthcare. Housing and healthcare integration with the goal of offering comprehensive services to our supportive housing clients. This position drives the development and implementation of resources and projects to better integrate care across Opportunity Council's housing and shelter programs. So that's a big job. That's a big undertaking. We have a lot of units and serve a lot of clients. So thank you, Mike.
Yeah, it's exciting.
Okay. Thank you all for being here. Here's my cat. Her name is Monster. On this note, I'm going to bring the meeting to a close, and I thank you all for joining us today, and I'm really looking forward to the time seeing you next time in 2 months. Thank you, and have a great night.
Thanks a lot.
Thanks, Terry. Good
Thank you.
meeting.
That was some incredibly difficult note-taking. You are muted.
Thanks for doing that, Chris. I'll share the recording with you and save in the chat, so that should help a little bit.
My notes are actually pretty solid.
Okay, great.
So there's a couple things I have to double check to make sure I got right. I also copied the entirety of the chat log and added it to the notes.
Perfect.
Just in case.
Thank you, Chris.
Send that off to my email, and then I'll clean them up a little bit and ship that off to you tomorrow.
That sounds great. I hope you have a great night.
I hope you do too. Take care of yourself and try to relax a bit tomorrow.
Yeah, I might be working, but we'll see. Anyways, have a good night.
Grumble. Okay.
I'm turning off Zoom, so y'all have a good night.
Good night.
Bye.